anything.
Okay.
Do you want me to record it and share it with the group rather?
I already started recording it. So,
okay. You'll just let me know when to start?
Okay, yeah, I'll let you know. We'll start at around 5 past as soon as everyone joins.
Cool, I don't mind. Just let me know. Sorry, I'm just working on some other stuff in the meanwhile. How many people are you expecting? Just out of curiosity.
The last lecture was about 50 people.
Okay.
So,
It's
yeah.
just curiosity. I really don't mind.
Okay. Okay, I think we can start now. So can I just make sure from the audience, can everyone hear me? Okay, that's great. Okay, so good afternoon, ladies and gentlemen. Thank you for joining us today. So I'd like to welcome all of you guys to our lectures today. So for those of you who are new to this term, obstetrics is a study focused on pregnancy, childbirth, and the postpartum period. So as clinicians, we understand that maternal morbidity and mortality are serious health concerns. Providing quality obstetric care is a critical point in identifying and managing complex cases. In this talk, our guest lecturer will be talking about surgical challenges encountered in the field of obstetrics. I'm honored to welcome Prof. Adam, who is a professor and maternal and fetal medicine specialist at Steve Biko Academic Hospital in Pretoria. Prof. Adam, the floor is yours.
Thank you, and thank you for this invitation. So what I've learned in the last year about these online meetings is it's very unnerving. It feels like I talk to myself. I can't see who my audience is. I can't see which of you are nodding or nodding off to sleep. So please, this is interactive. Please stop me. I really don't know the spectrum of who I'm talking to, and I can't see you, obviously. I'll leave the video on so you can actually see me, so at least hopefully I don't put you completely off to sleep. Well, I was surprised that the Student Surgical Skills Society invited me to actually talk about surgery, because I don't see myself primarily as a surgeon. I'm an obstetrician and gynecologist, which is a surgical specialty, but I spend more time in maternal and fetal medicine, which is the care of high-risk women and looking at fetal abnormalities and screening for abnormalities. So when you do, or if you have, at any time, you are welcome to visit our unit and see what we do and learn more about it. So it is a subspecialty of obs and gynae, but please pop in and we will be happy to show you what we do within reason. All right, so there are some procedures that we do that we'd rather not. So if we look at, oh yes, just one thing. If you have any questions, please just raise your hand or whatever it is, you're welcome to interrupt me. As I say, I can't see you, so I've asked someone to just facilitate because I'm sharing the screen, so please bear with me. So cesarean sections are probably one of the oldest operations, both in Western and non-Western literature. It's thought to have, the first one is thought to have been from the birth of Julius Caesar, but this is unlikely because his mother actually survived. So way back when, Caesars were performed on a dead woman to actually salvage the fetus, or in some religious or cultural circumstances where the dead fetus should not be buried inside the mother, it was used to extract that. And this was basically the pattern until the era of anesthesia, which started in the 1800s. There's a lot of mythology around cesarean sections, and if you look at older pictures and artworks, you'll see lots of people around it. It looks more like butchery rather than surgery, nothing graceful. And if you look at all of these, the center of attention is the fetus, or the baby rather, than the mother, who looks pretty much dead in these pictures. This is very different from what you will see in today's day and age, where the mother is awake in ideal circumstances with regional anesthesia. She's very much part of the procedure. So although there's a screen, there's an anesthetist looking after her. The father is part of the whole process. The baby is shown to the mother and handed over to the mother for early bonding if everything is going well with the mother and fetus. So we've come a long way from cesarean sections on dead mothers. So if we look at this, if you have followed even just popular media, the rate of cesarean sections has been increasing drastically without a concomitant decrease in perinatal mortality. This is driven by various factors, some of which we don't completely understand, but litigation and the litigious environment that we work in also makes it one of those situations that drives it. So the WHO has started a project or a drive to actually decrease the cesarean section rate, and they quote that the optimal cesarean section rate should be less than 15%. And they postulate that above 15%, there's no benefit on perinatal mortality. So it doesn't improve outcomes, but it increases the rate. However, there's large disparities between cesarean section rates between different low and middle income countries and basically the first world, also between rural areas and more urban areas. So if you look in South Africa, and I'll show you some data, if you look at different provinces, there's quite large disparities. And we, in Steve Biko, which is a high-risk unit which treats sick mothers, we have a cesarean section rate of about 40 or 50%. But if you go into sort of the Northwest or into the Northern Cape, which has much sparser healthcare facilities, it may actually only be about 8 or 10%. And then if you go into more rural Africa, and more into Northern or Mid-Africa or Central Africa, you're getting cesarean section rates of about 8% with quite high perinatal mortalities. But then again, if you go to the private sector in South Africa, their cesarean section rates approach 100% or at least 90%. And I'm sure a lot of you as healthcare professionals or future healthcare professionals have been asked by your friends, cousins, sisters, whoever it is, what should they do? Should they have a normal vaginal delivery or should they have a cesarean section? And if you haven't been asked, you're going to be asked that as a healthcare professional. What would you do? And that's a difficult and very loaded question because what should we really do? So the reason I chose to speak about cesarean sections is it's a common surgical procedure. You will be part of these operations by assisting as a student, and in internship, it's one of the requirements for you to be signed off as an intern. So all interns, whether you plan on being a surgeon or not, whether you plan on being a psychiatrist or you plan on leaving medicine and never doing medicine again, if you're going to do internship, you're going to learn to do a cesarean section. So I think it's important to know what the risks are associated with both cesarean sections, both basically acute or short-term risks or risk associated with the procedure, both to the mother and the fetus or newborn, and what the long-term risks are, so you are able to actually make good decisions and practice evidence-based medicine. So indications for Caesar, and let's not move away from the fact that cesarean sections are life-saving for both mother and fetus. There is a place in modern medicine, and it has revolutionized maternal morbidity and mortality and fetal morbidity and or neonatal, perinatal morbidity and mortality. In the past, if a woman had obstructed labor or if she had cephalopelvic disproportion or there was fetal distress, this mother and baby were essentially doomed to die. Cesarean section and fetal monitoring has revolutionized that. So now if we pick up obstructed labor or abnormal lies, like a transverse lie, or if there's a cephalopelvic disproportion or fetal distress, a cesarean section saves the mother and baby. But if we don't have competent surgeons, or if there's poor training, or if there's poor training in how to manage emergencies that may arise, this still increases morbidity and mortality. So there is a need for clinical guidance to actually guide clinicians and women in their decision making about the correct timing of birth. So if we deliver too early, there are consequences of late prematurity. Shared decision making, so the woman knows what to expect and she knows that she's making the right decision for herself. So if we talk a little bit about informed consent, we move from basically medicine where we had paternalistic decision making, where it was what the doctor said, the doctor makes the best decision, the doctor is always right, and move towards more sort of evidence-based or letting a patient make the decision, but the patients aren't always able to make the decision independently. So shared decision-making actually looks at shared responsibility between the clinician and the patient, means that the clinician needs to provide the best possible advice and give an opinion on what's the best possible option in that situation. So if she has a breech presentation, should she really be having cesarean section? And you've got to take, or should she attempt a vaginal delivery? And this takes into consideration where she is, what's her risk factors, how big is this baby, what skills are available, and looking at all of those things to actually make the right decision. So if we look at previous cesarean sections, if a patient has the initial cesarean section, she's more than likely doomed or destined rather to have a repeat cesarean section. And if she had one at the first one and she has 4 children, then she may end up with Caesar number 4, which increases morbidity with each increasing cesarean section. So the idea is to prevent the first cesarean section so we don't have a scarred uterus, and in consequence Caesars to consider a trial of a labor after cesarean section. With twin pregnancies, should all twins be delivered by cesarean section, or is there a place for vaginal delivery? And best evidence shows that there's no difference in outcome if the first twin is in cephalic position, leading is coming out with head first. There's no difference in outcome whether we do a cesarean section or we do a vaginal delivery. Similar with singleton breech presentations. If the baby is not an extreme preterm or exceptionally large, mother has an adequate pelvis and there's no other risk factors, a breech delivery is actually has about the same outcome in the long term as a cesarean section. However, what has been happening over time is because people have been deferring to cesarean sections, people have lost the skills, and clinicians and obstetricians and gynecologists and midwives have lost the skill to actually do a breech delivery. Placenta previa. So this is a double-edged sword. A placenta previa is where there is a low-lying placenta that overlies the cervical os. This is an indication for a cesarean section, and I think that's pretty much, if it's overlying the os, that's pretty much straightforward. We do a cesarean section. However, the more cesarean sections we do, it increases the risk of placenta previa, which is associated with its own complications such as antepartum and postpartum hemorrhage. Vasa previa is where there is basically a vessel from the umbilical cord that overlies the cervical os. This can be diagnosed antenatally if we do a transvaginal sonar and look at vessels flowing over that. Again, there's a difference of opinion on whether an elective Caesar prevents hemorrhage from that baby. With preeclampsia, should we do cesarean sections or should we actually do a trial of delivery? And we usually are on the side of doing a trial of induction and delivery. However, in a situation where we have a patient with HELLP syndrome or eclampsia, that's seizures associated with severe hypertension in pregnancy, and there's a poor Bishop score, it's an unfavorable cervix, where we think it's going to take a long time from the onset of induction to delivery, should we then do a cesarean section? And there aren't clear guidelines for this, and it's left to individual clinicians or units to make their own guidelines. Abnormal lie or presentation. So if we have a patient in a breech presentation or a transverse lie rather than a cephalic presentation, should we do a cesarean section primarily, or should we allow an external cephalic version, which is manipulation of the fetus while the woman is still pregnant and before she goes into labor to get the baby into cephalic presentation? Again, because we haven't done these things for so long, younger or more recent qualified clinicians have actually lost these skills, so it becomes unsafe procedures just because we don't know how to do it. With fetal growth restriction, which is one of the causes of increased perinatal mortality, should we be doing cesarean sections or allowing a trial of vaginal delivery? A fetal growth restricted fetus is a baby that's not growing optimally because usually either placental factors, fecal factors, or maternal factors. So this is a baby that's already got limited reserves to tolerate the stress of labor. Should we be, again, this difference of opinion. With patients with increased body mass index, and if you look around you, you are seeing more and more women, or if you look at our population, more and more people who are obese or morbidly obese, and we are one of the most obese nations on earth now. So more and more women are actually falling pregnant once they are obese. Normal monitoring and a vaginal delivery may be challenging, but cesarean section in these women are also associated with complications of difficult surgery and with a postpartum hemorrhage and sepsis. But then we come to the point, and while those can be justified and there may be some guidelines, what about the cesarean section on maternal request? What about the mother who says, I want a cesarean section on this day because I'm afraid of labor. I'm afraid of the pain of the contractions. What if she says that she doesn't want to do this because she won't have support, especially within COVID, where we can't allow partners into the labor wards? What about the mother who then comes and says, well, I've got to go to work, so I want to have the cesarean section today so I can recover and go back to work because I'm going to fly at a certain date. Or this is my grandmother's birthday and I want my baby. And these, as strange as it may sound, this is what we hear quite often, and we've got to navigate this. And then there's maternal cardiac disease, which depends again on the underlying cardiac disease. And then there's herpes, which also there's problems with. So if we look at a cesarean section, what we come down to is a cesarean section is a life-saving procedure for both mother and fetus in the correct circumstances. We need to choose the right patient for the right indication at the correct gestational age. If we can, we want to err on the side of elective cesarean sections because emergency cesarean sections are associated with more morbidity and mortality. So first, we need to prepare the patient. So the patient needs to be counseled about what this entails, about what's going to happen, who's going to be there, what the anesthetic entails, and preferably the anesthetist should see her and actually counsel her on that. On the fact that we will aim for regional anesthesia, and with regional anesthesia, she will be awake. She will be able to actually feel us stretching and pulling and all of those things. She shouldn't feel pain though. Positioning the patient. If you think back about the physiological changes of pregnancy, which this large uterus, if the mother lies flat on her back, we're going to get aortocaval compression, which drops her blood pressure. So she needs to be in a left lateral position, so either to tilt the bed or to use a wedge. And then we look at the selection of the skin incision. So there are multiple skin incisions, and the skin incision doesn't reflect the incision on the uterus. So you may find that the fanal skin incision, which is about 2 finger spaces above the pubic symphysis or the upper level of the pubic symphysis, and is sort of a smiley face, may be the most common incision used. However, Joel Cohen is probably, for someone who's learning or basically a junior surgeon, probably the safer incision, as it is further away from the bladder and has less blood loss. A malar incision can be used in obese patients, and a midline incision can be used usually in smaller fetuses. So if it's an extreme premature fetus, if there's large masses obstructing, or if there's if we need to do a classical cesarean section for a transverse lie or placenta previa. The uterine incision, on the other hand, can be a lower segment transverse or a classical cesarean section. The lower segment transverse incision is probably the safer incision to do and is the more common, but this can only be done if the lower segment has been formed, which only forms at around 28 weeks gestation. A classical Caesar may be used if it's a very early cesarean section or hysterotomy, if there's masses like fibroids obstructing the lower segment, again if there's abnormal lies, if there's a anterior placenta previa to avoid the placenta, or in some other situations which may be rarer, but this is left up to the decision of the surgeon. The lower segment transverse incision is the ideal because this is the much thinner part of the uterine muscle. And with this, the patient can have a repeat vaginal or a trial of labor following a cesarean section, with the risk of rupture being only 0.5% in subsequent pregnancies. On the other hand, with a classical cesarean section, that risk goes up to 10%. So 1 in 10 patients with a previous classical Caesar will have a rupture in consequent pregnancies, compared to 1 in 200 with a lower segment transverse. In some situations in difficult cesarean sections, and this is not advised, we may have to extend to a T incision, meaning you've done a lower segment transverse incision and for some reason you cannot access the baby, then we may have to extend the T incision. The problem with this is that where the 2 incisions meet, that area, that confluence, does not heal properly because of poor blood flow. Before we go on, I'm not sure how many of you have actually seen a cesarean section. I'm going to switch very quickly, hopefully this works, to this one. Okay, so I know you're not going to hear the sound, but I'm going to go through this. Oh gosh, I think I'm on the wrong one. I think it's already gone through. Sorry, I just want to see if this video of the cesarean section is going to play or not. If not, that's not going to be great. Let me just check. Sorry about this, guys. I just want to try and get this to work quickly. Are there any questions while I get this to work? Are you guys there?
Yes, Prof. Someone just asked, is delivery C-section or natural more difficult when a female has fibroids?
It depends where the fibroids are. So if it's covering the lower segment, so fibroids can have different effect on fertility, and it depends on the fibroid and the type of fibroids. So I can't go into that at this point, but you may get fibroids that go into the cavity. You may get fibroids that actually are in the myometrium and fibroids on the outside of the uterus. If they're on the outside of the uterus, they're usually not a problem. And if they're high up, they're usually not a problem, though they may cause problems with contraction of the uterus and predispose to postpartum hemorrhage. However, if a patient has uterine fibroids in the lower segment or cervical area where it's going to obstruct the passage, then we'd rather offer cesarean section. Now, if the fibroids cover on the where the lower segment incision would be, or disrupts the area where your incision is, we don't want to cut through a fibroid. Remember, fibroids are not very vascular, but you can't put sutures through them because they're tumors essentially. They're benign tumors. So we want to avoid the fibroids because they interfere with contractility and will interfere with closure. So most of the time not, but sometimes the patient with multiple fibroids all over the anterior part, you've got to end up not making a very nice incision to avoid the fibroids. So yes, it can be challenging, and those sort of Caesars should be referred. So preferably you diagnose this before the Caesar, and then that's referred to a high-risk unit where someone is able to do that Caesar and deal with complications should they arise. So if you can't close the uterus and you have to do a myomectomy, not ideal, but if you have to do that, you're able to do that. Or if there's postpartum hemorrhage, they're able to manage that. Does that answer the question?
Yes,
Sorry,
I think it does.
It's very difficult when I can't make eye contact. Yeah. So, okay, I'm not gonna go through the whole video, but just for those. So if you go to theatre, you're going to find there's a whole lot of instruments. We want to use non-traumatic instruments because we don't want to tear the uterus. Remember, the uterus is around the size of my fist. Someone is requesting control. Should we give them control?
No, I think it's probably a mistake.
No, it's fine. If they want to present, I'm cool with that too. So the uterus is the size of my fist. But because of pregnancy, remember, it extends all the way up to the xiphisternum. So if you look at it, it's quite thinned out because of stretching. So that uterus can stretch quite a bit. I would encourage all of you to take the opportunity to actually assist at cesarean sections, because if you're an assistant at a cesarean section, you actually can feel the uterus. You can ask the registrar to show you the anatomy, show you where the uterine arteries run, and show you the rest of it. So what do you think is the average blood loss at a cesarean section? Anyone? Someone want to hazard a guess? Okay, average blood loss at a cesarean section is about 750 mils. So this is a bloody operation as compared to about 300, 350 at a normal vaginal delivery. So there is more blood loss. You need an understanding of the abdominal wall. You're going to go through skin, and then you're going to use blunt dissection to actually go through subcutaneous tissue. And if we are doing phalansteal or a midline, to go through the sheath until you get to the visceral peritoneum. Sorry, for the sake of time, I'm going to accelerate through this. And then if you go through that, we use blunt dissection like this is. And like you're going to see, there's going to be lots of stretching and pulling and all of that. And the patient can feel that. She doesn't feel pain, or she shouldn't feel pain, but she will feel the pulling and all of all of that. So there, they've gone through the skin and the subcutaneous tissue. They're now going through the sheath. So that's then the rectus abdominis, and find an avascular plane in the rectus abdominis to then stretch that out. So we don't cut through muscles. We use stretching, blunt dissection, all right? So this is to release the aponeurosis so that you actually can get more space. But you need to create enough space to get that baby out. Remember that baby's head, the diameter is at least 10 centimeters in a term baby. And if we have bigger babies, it's going to be even bigger. All right. And then if we go on a bit further, so then we actually stretch the muscles. So eat breakfast if you're going to be in theatre for a cesarean section. And then we pick up the parietal peritoneum, and we find, again, make sure that there's no bowel between the two. And you're going to stretch that. Okay, so use a scissors to make that incision. And then again, more stretching, lots of stretching at a cesarean section. That's a Doyen's retractor, so that's used to retract the bladder. And a surgeon may or may not reflect the bladder peritoneum. It doesn't need to be reflected, but some may prefer to do that depending on where the bladder is. So on previous Caesars, sometimes you may have to reflect it because it has actually, it's adherent to the plane where you want to cut. So then again, you're going to free the lower uterine segment like they're doing. And then you're going to cut through, make sure not to cut the presenting part of the baby. So you're going to make an incision very carefully. As soon as you see the amniotic sac, you can do that. And as you can see, there's the baby's head, and you can see hair. And you see liquor coming out. So again, wear closed shoes. to a cesarean section, unless you want blood and amniotic fluid in your shoes, which I don't recommend.
Sorry, Prof.
Yes.
There's another question that was asked. Why do some doctors put the patient to sleep during cesarean section?
Okay, so routinely or basically we would rather do a spinal anesthesia for a cesarean section. However, if the patient has been fitting in some cardiac lesions, if she's got low platelets, or if there's a failed spinal, or sometimes it's the patient's own choice in rare circumstances, we will do a general anesthesia. If it's a cord prolapse or a severe cephalopelvic disproportion, or it's a patient with antepartum hemorrhage, we would do that because we anticipate in some of those circumstances, we want a rapid anesthetic, and a GA is much faster than a spinal. And in some circumstances where we anticipate hemorrhage or an unstable patient, we would rather do a general anesthetic primarily. But usually we would do that. And then the third stage, sorry, just to interrupt, the third stage of labor is managed. Again, you ask the anesthetist to give oxytocin, you rub up the uterus, and gentle cord traction. So you don't pull on the placenta, gentle cord traction until it is removed. And then you look at the uterus, don't put a swab into the uterus, but make sure that it is complete and it's contracted. And then we close the uterine muscle in 2 layers. All right, so there you see the placenta is delivering. For the sake of time, I'm going to go back to the presentation, but I will share this with you. So if you want to go back and look at that, you can. All right. So let me just go. Are you seeing my PowerPoint or not? What do you see?
No.
Okay, let's go back to that.
You need to share your screen again.
Are we back at PowerPoint?
Yes, you can see your PowerPoint.
Okay,
now.
so we have, so like I said, the difficult cesarean sections. So don't underestimate a Caesar. Even Caesars that may seem pretty okay when you get in there may be adhesions unexpectedly because of prior infections. There may actually be a poor contractility of the uterus, so always be prepared. If we look at difficult access, we spoke about leiomyomas, we spoke about fibroids, previous abdominal surgery may cause adhesions, and the obese patient, if the pannus overlies, it could be difficult. If there's a deeply impacted head or an abnormal lie, extracting the fetus may be difficult, so you need to know how the baby lies before you actually go in there. And then, although this is a common operation, do not underestimate the fact that there may be bladder injuries, and if you go very wide on the uterine incision and if it tears into the corner and the uterine artery and you repair that, you may get ureteric injuries. Also with the bowel, that can also be injured. And then there may be abnormal placentation, either placenta previa or an accreta, and I'll explain what that is. So I said a placenta previa is where the placenta overlies the cervical os. In a placenta previa, or if there's previous uterine surgery or with repeated cesarean sections, we may get what we call morbidly adherent placentas. So in a normal placenta, in a normal pregnancy, the placenta is attached to the decidua, and there's a clear line of the stratum between the stratum bisalis and the myometrium. However, if there's an accreta, there is invasion into the myometrium, or further into the uterine wall, or in severe cases right through the uterine wall and sometimes even into the bladder. Now in these cases, so normally after delivery of the baby, we give oxytocin, and there is sloughing off of this, the placenta separates and there's sloughing off on the endometrium, which is the lochia. However, if there's an accreta, an increta, or percreta, this is not going to separate so easily because it's invading the myometrium. So it's already an abnormal placentation, and one needs to be prepared. This is beyond this talk, but we can see this sometimes on ultrasound, although it's only about 60 or 70%. So why is this a problem? This is a problem because the placenta is not going to separate. If you pull on it, what may happen is that, sorry, I'm on the wrong screen. What may happen is that it may actually then, what do you call this? May invert the uterus or cause more bleeding. Or if you haven't anticipated it and you actually pull on that, you're going to pull the myometrium out, and that's going to just lead to more bleeding also. So this is where there's actually placenta accreta, and they've planned the cesarean section. So they don't want to show you the video. They think it may be inappropriate for you. You are too young, apparently. Let's try this again. Sorry about this. This is the problem with all these proper videos. So as you can see, there's a lot more blood loss. You need experienced surgeons who can operate rapidly and go on to actually, so in this case, they remove the baby, they deliver the baby. They know it's an accretor where it's invading into the myometrium. So they don't actually deliver or pull on the placenta. So this is a classical Caesar where the baby is being delivered through the top of the uterus rather than the bottom, because the plan is actually to do a hysterectomy with leaving the placenta inside. So that's one of the options. All right. If you look at the whole thing, you will find that this is where they did the uterine incision. They've left the placenta inside, but now they proceed with a hysterectomy. If they actually deliver the placenta, this would have led to massive blood loss in this patient, which is what you want to avoid. So I think what I'm trying to say with this is that, can you see the PowerPoint again?
Yes, we can see it.
Okay. Repeated cesarean sections are not without complications, and doing a cesarean section itself poses a lot of possible complications. Another complication that we see with repeated cesarean sections, although rare, is sometimes the pregnancy implants on the cesarean section scar. So if we look at this is where the cervix is. This is a very early pregnancy. That's the uterus. Normally on this is ultrasound images on the right. Normally we would see that there's an endometrium with a gestational sac, but there this gestational sac is located in the cesarean section scar. If we leave this to grow, it will basically start bleeding vaginally and becomes very difficult to treat. If diagnosed early, we can use methotrexate, so medical management, and this is before she starts bleeding because this is a very vascular area. If we look at image D here on the right-hand side, we find they've done a hysterectomy, and that's where the cesarean section was, within the scar. So this can lead to catastrophic bleeding, which is very difficult to actually manage, because unlike another ectopic pregnancy, you can't clamp and remove the cervix. You're going to have to do a hysterectomy in less than ideal circumstances. If we look at short and long-term effects in maternal morbidity and mortality, in consequent pregnancies, as I said, there's an increased risk of uterine rupture, abnormal placentation, be it placenta previa or a placenta accreta or morbidly adherent placentas. There is an association with ectopic pregnancies and with preterm births and stillbirths. And the more cesarean sections a patient has, the higher the chance of having these abnormalities. Babies who are born via cesarean section have different hormonal profile. And also they have, because they deliver via skin incision rather than via the vagina, they have difficult exposures to physical, bacterial, and medical. And this actually changes their physiology and changes their microbiome. And this leads to altered immune risks and development. They have an increased likelihood of atopic illnesses such as asthma and other allergies. Their gut microbiome is actually quite different and more like skin microbiome of the mother rather than the vaginal microbiome. And these risk factors can persist into a later life. And if you read a bit more widely, you'll find that it can actually be associated with childhood obesity and asthma in later years. We don't know about neurodevelopmental outcomes. So Caesars, while we said that they are life-saving, in the wrong hands or in untrained hands or for the wrong indications, they pose a disproportionate threat to the lives of women and babies, especially in low middle income countries. And somehow they find that these countries with low rates of cesarean sections somehow have high maternal deaths and morbidity and mortality. And this probably has to do with access, the type of patients of low socioeconomic circumstances, higher burden of infections, lower HBs, poorer access to blood, poorer trained surgeons. So we need evidence-based training in labor management with good monitoring and a proper indication for a cesarean section, so we reduce inappropriate Caesars and prevent the first Caesar. So we need training with resource provision, skill training in instrumental deliveries, using the partogram, and also management of postpartum hemorrhage and neonatal resuscitation. So if we look at some of the South African data, you'll find that there's actually about a 20 or 30%, or about a quarter to a third of us deliveries in each province is by cesarean section, which is much higher than the recommended 15% from the WHO. If we look at the seizures associated with bleeding, we find about 20 to 30% actually associated with hemorrhage, which is quite unacceptable. And if you look at our maternal death or maternal mortality statistics, we find that a lot of these deaths are associated with cesarean sections, with postpartum hemorrhage at district level hospitals. At a district level hospital, it's junior doctors who do this, usually interns, community service, or medical officers. So we need proper indication and good surgical technique. With these slides, you'll find that outcomes or complications are much worse after second stage cesarean sections or emergency cesarean sections, and as can be expected with junior or non-physician trainees. Another complication we see in the non-pregnant state is with the cesarean scar, there's fluid collection in that niche basically, and this is called an isthmocele. These patients may present with an offensive, annoying discharge, and this is becoming more common as more and more women have cesarean sections. With pediatric consequences, like we spoke about, it's got to do with neonatal stress, the raised pressure, the level of catecholamines that are associated with vaginal delivery. With a cesarean section, especially with elective cesarean sections, the fetus misses all of this, and this changes the immunological and endocrine profile of the fetus, of the neonate. We spoke about economic coverage and the disparities, especially between the private and the public sector. We spoke about high prevalence, and there is a high, and it's been cited that there's high demand, and the more educated people are, the more access they have to social media or popular literature, the more aware they are of possible risk factors, the more they will demand cesarean sections. And this can also be seen more in less partisan societies where women have more say, as compared to patriarchal societies where a normal vaginal deliveries are still the option. So we need to reduce emergency cesarean sections by making antenatal care affordable and accessible, behavioral change, so change in the way people think, change in feeding habits and exercising to reduce obesity, and also to let patients know about the warning signs of pregnancy-related complications so that they present early. So if you look at what happens out there, there is a power imbalance. No matter how much we say we give patients options, patients look to clinicians or to the doctor to help them choose the right option. If doctors actually don't have faith in medical institutions, they themselves say, you know, something is safer, that's some sort of structural violence. If I say to a patient, I think, you know, there's a nuchal cord, this baby, you know, there's a cord around the neck on the sonar, the baby is going to go into, you know, fetal distress, that mother's going to believe me and be very afraid that she may lose this baby at this late stage, but there's no evidence for that. And then clinicians impose their personal beliefs on a patient. So if the clinician believes a Caesar is more appropriate or safer, and that the healthcare system is not safe enough for that patient, that is what the patient is going to choose. Again, you may read a lot about pelvic floor dysfunction following cesarean section, and while there is evidence of damage to the pelvic floor, there's no long-term evidence that having elective cesarean sections, a prophylactic pre-labor cesarean sections actually reduces that risk. So I don't think it's enough of a reason to say we should be offering all patients elective cesarean sections to protect the pelvic floor in later life. There's a lot of confounding factors. So while we say women's wants or needs drive the cesarean section rate, when they've asked women in both developing and developed countries what would they prefer, only 15% opted for cesarean sections. Some of them said that they had fear of labor pain, or they were economic, social, or cultural, but factors that influenced their decision. But clinicians' attitude or structural violence actually made women err towards cesarean sections. So
Sorry,
we need
Prof.
actually, yes, I'm almost finished.
There's just another question. So it says, Prof, do you have any thoughts on maternal vaginal swabbing and seeding of cesarean section babies to improve infant microbiota? There's very little research currently.
Okay, so I know the midwives do that, but we don't have good evidence that it actually translates to the same thing. So although you're taking the microbiome and you're seeding that with the infant, it doesn't stimulate the same sort of stress and catecholamine release or the same pressures in the baby. So while it may, to an extent, do that, there's no good evidence that it's the same as having a vaginal, it's not equivalent to having a vaginal delivery. So having a Caesar with seeding is not the same. It doesn't replicate the process. and we don't have good long-term evidence that it makes a difference. So we don't practice that. We don't have good evidence for that. I know some of the midwives advocate for it. So again, going back to stopping the the Caesar epidemic, correct patient, correct intervention at the right time by trained personnel, and also to make women aware of their choices. And rather than looking at a specific rate, rather look at a rate that's appropriate for the place you are and a right decision for the right women. So commitment again to women-centered care, empowering our patients, encouraging mother-baby friendly hospitals, educating patients. And if you look at this comes from WHO recommendations, and this is non-medical interventions. And if you watch a lot of movies and things, especially from the American part, you find Lamaze classes where there's birth preparation classes, and we don't have that. Teach them about relaxation, have the partner being prepared to what's available, have doulas available to actually assist with anxiety and pain management, and having better pain management options in our hospitals, which don't have epidural services in the public sector. So also looking at health professionals and how we look at this, practicing evidence-based medicine and implementing evidence-based guidelines. So not just knowing it, but practicing on that. Respectful care and inclusivity of women in decision-making and in their own healthcare. And facilities providing adequate staffing, adequate good equipment, and having in-house labor and delivery coverage without competing clinical duties. If some of you have been to Tembisa Hospital, you would understand, or you see what happens at Barrow, often where they've got backlogs of 20 or 40 Caesars. That's not, optimal. And these are the references that I've used. Thank you for this opportunity. Are there any other questions or any other discussion? Anything else you'd like to ask?
There is another question. If the previous cesarean section is vertical midline, where would the incision regarding the second cesarean section be?
Is this now the skin incision or the uterine incision?
Sandrula, would you like to elaborate? Both.
Okay, the skin incision is cosmetic, and that will be left up to the surgeon and discussing it. The uterine incision, if we can make a lower segment transverse, always go lower segment transverse. But the skin incision is essentially cosmetic and about access. So if she had, just say she had a first Caesar for a 600-gram baby, so they did a midline incision and they did a classical Caesar, but now she's actually got to term. It's a big baby, 3.2 kgs. I think for the skin incision, have a discussion with the mother about what's the best option, taking into consideration cosmetics, but taking into consideration access, infection, and hemorrhage, and wound healing. And the uterine incision, I would still go lower segment transverse. As long as I can do a lower segment transverse incision on the uterus, that's what I'll do.
Okay, there's another question.
Caesar, do you suture the peritoneal layers? No, there's no evidence for a suturing. I can't see the rest of your question. Let me see if I can see it. No, I'm not seeing the rest. Okay, what I can see of your question is that.
Probably I can repeat it if you want.
Let me answer it and then tell me if I'm missing something. So when we open the peritoneal layer, we may or may not reflect the visceral peritoneum. But when we close up, we only close the muscle, don't include the peritoneum in the uterine closure, and we don't close the parietal peritoneum, we just close the sheath. So your layers going in would be skin, subcutaneous tissue, the sheath, the parietal peritoneum, plus minus the visceral peritoneum being reflected, and then you cut through the muscle, the myometrium. Closing myometrium in 2 layers, the sheath, and then the skin. Did I miss something on that question?
I think you got most of it. They just also added, if not, does this not lead to more adhesions?
No, actually closing more layers leads to more adhesions. So it's been shown if we close that many adhesions, so adhesions would come more suture material, more adhesions. So you want meticulous hemostasis and prevent infection. That would reduce the chance of adhesions. I saw there was a question, but I can only see about repeat or what would I advise about cesarean section?
Yeah, it says, could you please repeat whether you would recommend cesarean section or natural birth for fibroid high up in uterus?
If it's high up in the uterus, I would, and it's not obstructive, I would still advise a vaginal delivery, as long as the baby is in a longitudinal like cephalic or a breech presentation. But I mean, with a breech, it'd obviously be other factors. So let's say cephalic presentation, everything else okay, fibroids high up, I'd still go with a vaginal delivery.
Okay. Are there any other questions?
I know the presentation had a lot more words than what I said, but that's for a reason, and I will send you a copy of the PowerPoint now.
Okay. Thank you very much, Prof.
Thank you.
So it looks like there's no more questions. Okay, so yeah, I'd just like to thank everyone for attending the talk today. Also, special thanks to Prof for taking your time to give us this lecture.
You're welcome.
We'll be sending you a gift that's a token of appreciation.
Thank you so much. And thank you all for attending. I'm sorry, it's very difficult because I can't make eye contact or see who you are, but I appreciate you attending. And thank you again for inviting me.
Okay. Thank you very much. Enjoy your day, everyone.
Bye.
Bye, guys.